So thank you very much. I'm delighted to be here today, and I did my undergrad here at UIC, so I'm actually very familiar with this building and this venue. So I became interested in tumor immunology when I was a fellow at the NCI, and one of the things you do as a fellow is you pick up the last fellow's patient load, and they were doing a treatment then called interleukin-2. And one of the things I would do when the patients would come in is I would pull up their old scans. In some cases, they were chest x-rays back then. And I saw some patients who had their disease completely disappear. Some of these patients were 10, 11 years after treatment, and I just couldn't get it out of my head what is going on inside of these patients. And so I saw firsthand what the immune system can do. And so it's been a very interesting journey because this was, we were kind of the voodoo kind of physicians focusing on this for many years. And I think the world completely changed with respect to immunotherapy in 2011, just about 5 years ago. And so today what I thought I would do for precision medicine purposes is show you some of the general concepts that we're thinking about in the field right now. And I'm going to finish up with how I think this can integrate very nicely and very conveniently into precision medicine paradigms. So first of all, in cancer care, we have sometimes referred to these pillars of treatment, with surgery, chemotherapy, radiation therapy being the three main pillars. And with the sequencing of the human genome and the advances in precision medicine, we now have really a fourth pillar of really trying to target specific mutations in patients. And I'm going to argue to you today that we actually have yet another pillar in immuno-oncology or immunotherapy. And this is a particularly important pillar because when we get complete responses with many of the immunotherapy agents, these seem to be quite durable. And in fact, some of us are even daring to get up on stages like this and talk about the possibility that we have actually cured some of these patients, even of widespread metastatic disease. And I certainly think that that is true. And understanding what's going on in those patients and how we can expand it to everybody else, I think, is going to be the next challenge. Well, one of the first paradigms is I study melanoma, and immunotherapy used to be something that was synonymous with melanoma. And melanoma was an interesting disease because we were sometimes referred to as the graveyard of drug development because whatever drug you had was sure not to work in melanoma. And so we went for many years really not having much to give our patients, and then all of a sudden melanoma has become the paradigm in many ways for both precision medicine with really understanding the BRAF/MAP kinase pathway and how to target it, and now with immunotherapy. Without a doubt though, today we know that immunotherapy is now impacting many if not all cancers, and it's no longer exclusive to melanoma. Jimmy Carter has, whether he wanted to or not, I think become our best spokesperson. And actually I was at a dinner last week where he received a Courage Award for his melanoma therapy. He's now completely disease-free, which is really amazing at 92. So when people say it's not something that you can tolerate easily, I think it is. And you can see the number of FDA approvals that have occurred have been across the board, and certainly lung cancer, which is the most common cancer that we deal with, being responsive to immunotherapy has completely changed the paradigm and gotten not only every oncologist interested in immuno-oncology, but I think every pharmaceutical company and industry as well. So I thought I'd take you a little bit back where we were. So this overnight success is about 120 years old in terms of the modern era. And most people will say that immunotherapy really began in the 1890s with William Coley's observation that some of the patients who were waiting for surgery got what we think is erysipelas, probably a strep infection, but nonetheless the tumor would regress. And Coley spent much of the first part of the 20th century going after what he thought was some toxin in the bacteria that was somehow killing the tumor cells. We now think that what he was really looking at was the immune system really getting able to eradicate the tumor, and probably happens in a very few number of patients. Much of the 20th century, though, really there were not many advances. BCG was used. We injected in melanomas back in the 1960s and 70s. I've heard several people take credit for that, interestingly. And although BCG hasn't shown benefit in melanoma, it is actually an FDA-approved drug for the treatment of superficial bladder cancers. And interferon got approved for a number of indications, including adjuvant therapy in melanoma and renal cell carcinoma, hairy cell leukemia. And in 1992, interleukin-2 was approved for treating renal cell carcinoma, and then in 1998 for melanoma. However, see what's happened after 2011, and all these blues are new FDA approvals. In fact, this was the one thing I had to update this week because there was just another first-line lung cancer approval. And we are widely anticipating several more approvals that will be coming up in the next few months for a number of other diseases. And you can see that the field has completely taken off in 2011. So what do we know about the immune system? Why does this happen? So this is really a summary of work that was really pioneered by Bob Schreiber, along with Lloyd Old and Mark Smith. And really what they've shown very nicely in the mouse is that the immune system does function to survey for tumors. And in fact, this is an evolutionary race between a tumor cell evolving to escape the immune system and the immune system able to evolve to contain a cancer, a growing cancer. So early on in the development, we think that the immune system is able to deal with a small number of mutations, a small number of abnormal cells, and will result in tumor elimination. And in fact, that may be why we don't see more cancer than we do now, is that we may be all getting cancers at various times, and yet with a healthy immune system, you are in fact able to contain the tumor. At some point, I know this group likes to think about mutations, so maybe you can think of the mutation rate of the tumor and the ability of the immune system to evolve reaches a kind of steady state, and you have what has been termed equilibrium. And in fact, this has been proven in mouse models. That this state occurs, and mice that have tumors where you're at this equilibrium point, the tumors will not grow, but they also will not regress. Eventually, of course, we know that clinical detection of cancer occurs, and the cancer simply escapes the ability of the immune system. And what's really happened in the last few years is we really understand more of the molecular and cellular mechanisms of this process, and we know that tumors, as clever as they are, we've already heard that theme this morning, they also have to get rid of the immune system in order for them to grow and survive. And so understanding how the cancer cells are in fact dealing with the immune system has allowed us to intervene in fairly clever ways, and this seems to be very effective. Just to show you exactly what's happening, I have this brief movie. The green are green fluorescent protein-labeled melanoma cells, and the blue are CD8 cells that recognize a melanoma antigen called MART1. And in the laboratory here, you can see that the blue cells can directly kill the melanoma cells. An important point of this is the T cell is then still alive and can circulate around to wherever there might be a melanoma cell and kill it as well. So in terms of targeted therapy, this is probably the most exquisite targeted therapy that you have. And some percentage of these T cells can stay on as memory cells. So just like if you're exposed to measles when you're young, you won't get it again when you're older. The reason that happens is that you have a memory set of these T cells that can recognize the virus. And we think that when patients have complete responses to tumor immunotherapy, these T cells will stay within the circulation, and if cancer arises again, they can in fact go and continue to eradicate the cells, the tumor cells. Now, the process for getting the immune system to do this is very complicated, and so this is a nice summary that was written by Ira Mellman and Dan Chen, published in Immunity about 2 years ago, and it really shows the basic principles and summarizes about 100 years of work here. So we think that what really happens is that tumor cells, by virtue of the genetic instability, will produce various mutations that are not found in the normal cell counterparts, and these can serve as antigens for the immune system. Now, these antigens have to get out of the tumor cells. This may occur due to normal necrosis of the tumor. It can occur following radiation, and we now know even chemotherapy can induce the release of these antigens. They then get picked up by dendritic cells, will travel to lymph nodes, where they then get presented to T cells. The T cells then need to traffic back, largely under the influence of a chemokine cascade, and then that T cell can recognize its antigen at the tumor site. Now, this process takes a while to occur, and that is going to have some important clinical consequences. So unlike chemotherapy or targeted therapy that directly kills a tumor cell, the immune system takes a while to mediate this process. This also gives us many, many areas to intervene and to kind of help this process. And we now know that cancer can disrupt all of these processes in an effort to really escape immune detection. So another really important concept that we've developed is when you take a look at some of the cellular subsets within the immune system, we know that some of these cells are very effective at recognizing and eradicating cancer cells. For example, CD8 cytotoxic cells. Within the CD4 pool, the Th1 phenotype is particularly good for getting rid of cancers. However, some cells turn out to be suppressors. So within the CD4 pool, Th2 cells actually do not support eradicating tumors. Regulatory T cells actually are particularly problematic in cancer. There's now been a lot of data that these cells are found in very high levels in cancer patients, and they can actually shut down immune responses. We see a similar kind of pro and anti-tumor growth within the monocytic cell subset, so that certain macrophages can be protective against cancer, and others, such as myeloid-derived suppressor cells, M2 macrophages, may promote tumor growth. And in fact, as you might imagine, there's a great deal of work going on to try to target these cells. And I think, by the way, it has implications for other diseases, because if you can activate the tumor cells in cancer, you could also block those in patients with autoimmune disease and in trying to get transplant tolerance. And so I think some of the drugs that are in development now for the immune system are actually going to have much wider impact than just oncology. Now, one of the other things that we've learned about cancers, I've just told you that this may take a little while to see an effect. And I'm showing you here on the left the pivotal phase 3 trial that led to the approval of vemurafenib, which is a BRAF inhibitor in melanoma. And on the right, I'm showing you the survival curve for patients on the ipilimumab trial. This was an immunotherapy to target CTLA-4. And what I want you to notice is that the shape of these curves looks very different, and it really highlights a really important difference between targeted therapy, at least as it is today, and immunotherapy. So if you look at the top, the treatment group and the control group when targeted therapy diverge almost immediately. This is the profound effect, the slide I think that Jimmy showed you of the tumors going away right away. But what you see is that within about 7-8 months, the lines come back together again, and this is due to the rather uniform emergence of resistance with targeted therapies today. Now, if you look at the immunotherapy curve, what you'll notice right away is at the beginning, the lines are absolutely overlapping. And in fact, early studies looking for progression-free differences between patients in control groups and immunotherapy studies didn't show anything. And in fact, the progression-free survival in this particular trial was completely negative. But if you follow these patients for a longer period of time, you see that the tail of the curve goes on, and that means that these patients are still alive. And there's now been 5-year and further follow-up, and about 21% of patients who receive ipilimumab in melanoma are still alive 5 years later, and probably are cured of their disease. And so this is the real difference that we see with immuno-oncology. And the real question now is, how do we take that slope of the curve, that straight line, and raise it up higher so that more patients are getting into this long-term survival? Now, I want to show you in practicality how powerful immunotherapy really is. So this was actually a patient who has, as you can see, a pretty hard-to-miss melanoma growing off the back of his head. That's his ear over there. And this patient was actually treated with adoptive cell therapy and interleukin-2. But what I want to point your attention to is the days here. So this is the tumor 7 days before starting therapy. 3 weeks after entering into the therapy, the tumor is clearly necrotic, and within 2 months, it demarcates and goes off. This patient went on to have a complete response, and I think the only lasting side effect is he became an Orioles fan. What really changed the field, though, in 2011 is the understanding of how T-cell checkpoints work. And so I'm going to give you just a short immunology lesson. So we know that T-cells, I told you that there are some effector cells and there are some suppressor cells. The immune system also can regulate things at the individual cell level. So even within an effector T-cell that can eradicate a cancer, it undergoes a very tight regulatory pathway to turn it on and turn it off. Why does it do this? So if you have an acute viral illness, you want to get a rapid burst of T cells to eradicate the viral infection. If those T cells stay active for a long time, you can induce autoimmunity and you can have a lot more problems to the host. If you've ever had the flu and you feel lousy, you don't feel lousy because you have a viral infection. You feel lousy because your immune system is very active. And so you need to shut that down, and you need to shut it down quickly. So in the case of acute viral illness, there are a number of receptors on the surface of the T cell that when the virus is cleared will actually regulate the downregulation and even killing of the T cell. Now, in cancer, you don't want those cells to go away. You want them to stay on. And so this is a really important point. So in order to activate a T cell, it really recognizes its antigen when it's bound to an MHC molecule on a dendritic cell. And if that is the only thing that occurs, the T cell actually will not become activated. So it needs additional signals, which have sometimes been termed secondary or co-stimulatory signals. And one of those is given by B7 family members. There are several of them on dendritic cells. They bind to a molecule called CD28. And when the T cell receptor sees its antigen and the CD28 is signaling, that T cell is given an important signal. It will produce cytokines like interleukin-2 and interferon gamma. It will begin to proliferate, and it will be blocked from entering into apoptosis. Shortly after that occurs, a molecule called CTLA-4 will come to the surface, and it outbinds the CD28, and it actually delivers a negative signal to the T cell. It blocks cytokine production, it will inhibit proliferation, and in many cases, it causes the T cell to go into an apoptotic pathway. So ipilimumab was one of the first monoclonal antibodies that was designed to block this interaction, and so the CTLA-4 is no longer able to shut down the T cell, and it keeps it around a lot longer. Now, a little later in the course of the T cell, immunologists have known for many years that T cells can have an interesting phenotype that was referred to as exhaustion. These were exhausted T cells. They were like ready to die. They were going to undergo apoptosis. They're kind of suicidal. And the way that we marked these cells was by a surface receptor that we appropriately called programmed cell death 1, or PD-1. It was the marker that the cell's about to die. And PD-1 gets its signal from two receptors, which have been called programmed cell death ligand 1 and 2. And one of the big advances was the finding that many cancer cells will produce and express PD-L1. So if you ask yourself, why would a cancer cell in its busy life cycle go through the energy of expressing PD-L1, it's to bind to the PD-1 on the T cells and kill them. And so this suggests that if you block that interaction, you would in fact prevent the tumor from shutting down the T cell, and then the T cell would be able to do its job and kill the cancer cell. And so PD-1 and PD-L1 antibodies were made, and I think this has really changed the history of the field. And this does in fact work really well. Right now there are two PD-1s and one PD-L1 that are approved by the FDA. I'm told by my colleagues at FDA there are 22 new INDs of different PD-1 targeted approaches, and throughout the pharma industry right now there's thought to be about 40 different PD-1, PD-L1 directed agents in development. And of course, really remarkably, we had such success in the early days of these agents that some of the trials not only were stopped prematurely to take patients off ineffective control arms, but in a move that I've rarely seen, the FDA actually approved some of these agents with phase 1 clinical trial data. And I just talked to Rick Pazder, who's leading the oncology reviews, and he's pretty clear that the FDA may no longer require phase 3 studies if we continue to see some of the data that have been coming out of these. So importantly, these are waterfall plots. So these are tumor growth. So things going up, our tumors growing, things going down, our tumors regressing. And right now, PD-1 and PD-L1 pathways seem to be having significant impact in over 20 tumors. 21 will be Merkel cell carcinoma, and there are 2 clinical trials that are positive, and we're widely anticipating an approval for that bad disease shortly. Now, This is the ipilimumab slide, and again, what I told you is about 21% of patients seem to get long-term benefit from this, and so the negative thing to say is 79% of the patients are not benefiting from this. So what does the PD-1 data look like in melanoma? Well, it actually looks much better. So this is looking at different doses of PD-1. The purple line is the ipilimumab, and you can see that PD-1 appears to have slightly better activity. And in melanoma, with the different PD-1s out there, response rates have generally been in the 35 to 40% range. And again, these seem to be quite durable. You can see the slope of the curve, the tail of the curve going out like we would expect. Now, another really important paradigm that I'm going to tell you about, and actually if you invite me back next year, probably the only thing I would talk about is combining immunotherapy drugs together. Do you get a better response? And the early answer to that is absolutely yes. And so this is a study, again, looking at ipilimumab alone or a combination of PD-1 plus ipilimumab. And you can see here that almost 60% of patients appear to be in response and doing quite well. And as you can imagine, there are many combination clinical trials that are currently underway. Now, one of the other important paradigms that we learned about in this is I told you, I showed you that big cycle that this may take a long time to achieve an effect, and this actually has a clinical implication. So this is actually looking at a patient's tumor. The yellow lines are times that they were treated with the drug, and what you can see is, and I want you to notice, this is weeks, so we're talking 50 weeks is 1 year. And this is a patient who initially is treated with the red arrows are the 4 treatments. And initially, the patient's tumor looks like it's exactly the same, so it's kind of in this equilibrium phase. But then it begins to go down and continues to regress, eventually hitting a complete response, but it takes about 50 weeks or so for this to happen. Now, this doesn't happen the same way with every drug. This doesn't happen in every patient, but it's become a really important caveat that when you're treating patients on these immunotherapy studies, that it can be very tricky to follow them. And so imaging alone may not be effective, and so you really have to kind of put together your clinical impression of the patient along with the imaging and other sort of standard monitoring techniques to really see the full effect. Also, although I'm showing you the great advances in terms of the outcomes, this does come at some cost. And some of the side effects that have been associated with this treatment, as you might imagine, is if you're activating the immune response, you might see autoimmune type side effects. And that is, in fact, the major toxicity profile of these agents is you can see immune attack of the colon and colitis of the lungs. You can get a pneumonitis of the pituitary gland, a hypophysitis. And we've really seen almost inflammatory type reactions of almost all the different organ systems with these. We have good ways to manage this now. They seem to be very responsive to corticosteroids, but earlier intervention is important. And just like the tumor response can take a while, the side effects can take a while. So sometimes patients will manifest the toxicity months after receiving these agents. And so that's an important lesson for clinicians taking care of these patients. Oncolytic viruses are another area which I'll tell you about since I've done a lot of work in this. And oncolytic viruses really have a multimodal mechanism of action. So in addition to directly killing many tumor cells, and really taking advantage of the oncogenic signaling pathways within the tumor cells to preferentially replicate there, they also tend to release tumor antigens and danger signals that help to stimulate an immune response. And so one can directly inject a tumor, kill it, and then get an immune response. And so a lot of work that I've done with a HSV1 virus, this is the virus that causes a cold sore, in which the virulence genes, which are the ICP34-5 genes, have been replaced with the human GM-CSF gene. That's a cytokine that helps the dendritic cells to mature and stimulate a T cell response. Was generated. This virus only replicates in tumor cells. It doesn't seem to affect normal cells, and it can, in fact, induce an immune response, at least in animal models. This has been given the ridiculously hard-to-pronounce name of tolimagene laherparepvec, but I'll refer to it as TVEC. And we did a randomized phase 3 study, the first randomized prospective trial in patients with advanced and metastatic melanoma. And the study met its primary endpoint, so there was a 26.4% objective response rate, which I would point out also had almost an 11% complete response rate. So that means if we injected something in the skin or the leg and the patient had disease in the liver and the lungs, that went away as well. And it also had durability associated with it, which meant that the responses were lasting 6 months or longer. And that was the primary endpoint of the study, the 16 versus 2%. This is a swimmer's plot just showing the durability of the responses, and all those little black arrows on the end mean that patients who are responding still seem to be in response. And again, this the tail on the curves, which I didn't put in here, again look like this is a typical immunotherapy drug. Part of the reason I show you this is the side effect profile from this has been very well tolerated. We see some fever and chills the first day of injection that usually goes away the next day, response to Tylenol, and a little bit of pain at the injection site. The only serious adverse event that we've seen in more than 2% of the patients is a cellulitis, which I think is more a viral cellulitis, not a bacterial cellulitis. What if you combine the TVEC with one of the PD-1 inhibitors? Well, a trial is ongoing. There's about 30 patients enrolled right now. The response rate is actually 67%, but without the same toxicities as we've seen with the combined checkpoint inhibitors. And so this study was actually a collaboration between Amgen and Merck, and they stopped the study to redesign it as a randomized phase 3 study, and that study is now open and accruing patients. What I want to show you is that while I've talked about PD-1 and CTLA-4, there are literally several dozen of these T-cell checkpoints that are available. And so, as you can imagine, there's an intense interest in looking at some of these others. And we right now recognize about 320,000 mammalian viruses that might be able to infect tumor cells. And so I think the number of targets and potential drugs and combinations here is almost overwhelming for the field. What about combining immunotherapy with targeted therapy? Is that something that can be done? So here, again, can you take add in early responses and improve the tail of the curve as well? And I'm just going to share with you one piece of data that would suggest, yes, this might be a very promising approach. And that is some data that shows that melanoma patients who are treated with a BRAF or MEK inhibitor actually exhibit an increase of T cells into the tumor site. So this has been reported now a number of times. There also seems to be an increase in the neoantigen burden that occurs. And at least in mouse models, it suggests that there is, in fact, a strong synergistic effect when you combine BRAF inhibition with immunotherapy. And so clinical trials are underway. Now, obviously, what would be great would be to have a biomarker so we could identify which patient is going to respond to which of these agents. So just like in the genomics, you can look and see, well, what mutation does the patient have so we know what pathways to target. Could we do the same thing with immunology? So I think the answer is yes. It's a complicated pathway to develop biomarkers, which is the purpose of this slide. So don't worry, I'm not going to go through all of this stuff. But we already have a few really lead markers that we think are particularly important for selecting appropriate patients for this. So first of all, a very simple marker, I think we were talking about this last night at dinner, the T cells within the tumor is in fact a predictive marker of survival. So here is data that was published actually a while ago, ovarian cancer, colon, lung, melanoma. Those patients whose tumors have a large number of lymphocytes, period, do better, no matter what treatment they get, than those patients whose tumors do not have these T cells there. You might ask, why do some have T cells and some don't? We don't really understand that yet, although I'll show you some hints as to why that might be. This is work that was presented by Tom Gajewski's group, who's one of my colleagues at the University of Chicago, and he's really defined these two kind of phenotypes of melanomas that we see. In one, we see a large number of lymphocytes like CD8s. These tumors will have other markers, including high levels of PD-L1 expression, probably because the T cells are bringing interferon gamma there. There are other tumors that simply have nothing there. And he's referred to these as inflamed or sometimes hot tumors versus uninflamed or cold tumors. And the question is, why is that happening? And Tom has some very interesting data that certain oncogenic signaling pathways, such as the beta-catenin pathway and possibly also the MAP kinase pathway, tend to delete the T cells that are present. And that is why when you block those pathways, you can turn these back into inflamed tumors. Likewise, the oncolytic viruses, there'll be some data coming up showing that, in fact, needless to say, you have a virus now in your tumor, all the lymphocytes come in, and that will also change the phenotype, and it starts to upregulate things like PD-L1, and probably explains why those combinations are effective. PD-L1 expression alone was seen early on to correlate with good responses, and you can see here this is immunostaining that was done. There are many different immunostaining assays available, and you can grade these patients, and in fact the clinical outcomes actually do correlate, not perfectly, but there is a trend that does correlate with response. And this is data from melanoma. This is data in lung cancer. So if you look at both progression-free and overall survival, again, this is using a PD-L1 antibody. Those patients who had a PD-L1 expression greater than 50% seem to have a survival benefit. Likewise, we've learned something from melanoma, so that patients who had very high levels of PD-L1 expression, they were equally likely to respond to both the monotherapy and the combination therapy, whereas if the PD-L1 expression was low, they responded better to the combination therapy. And again, while this isn't 100% associated, some of my colleagues have suggested that maybe you could look at PD-L1, and then if the expression is high, you can give the patient the monotherapy and avoid the toxicity of a combination. There have been a number of gene expression profiles, largely that revolve around interferon gamma-related gene expression, and those patients who have high levels of interferon gamma-related genes seem to do better. And finally, mutation burden by itself seems to be very important in terms of response, and this is just looking at different tumors and the amount of mutations. And you can see that melanoma and lung cancer have the highest set of mutations here and go on down the line. And interestingly, where immunotherapy seems to be working best is when you see these high level of mutations. So not surprisingly, smokers with both lung cancer and head and neck cancer seem to be doing better with these therapies, probably because the mutation burden is high. And that is something that you guys are all testing all the time when you're doing the precision medicine profiles. And this is just data showing in lung cancer that, in fact, a high mutation burden and emergence of neoantigens is associated with a survival benefit. And so I think where we're headed in immunotherapy is really putting some of these markers together, such as the interferon gamma gene signatures, the genomic landscape, and then other mechanisms of resistance, and you'll be able to come up with maybe designing better therapeutic options for patients. Just very quickly, because of the difference in kinetics with these patients, there are a lot of issues with our current clinical trial designs. I think now FDA has been very public about saying that the designs we have were really developed for cytotoxic chemotherapy agents. They're really inappropriate for immunotherapy. I think we're going to have more meetings and workshops to come up with better endpoints and better clinical trial designs for these agents. And I even hate to bring this up, but cost is an issue, and there are some projections that at the current rate of use of these drugs, we will completely bankrupt Medicare within the next 5 years. And so I think we're going to have a serious conversation about the real value of these agents, because some of the current value platforms are not really taking into account the durability, and I think we have limited data to really know what the toxicity costs of these agents are going to be, but we have to have the discussion to continue development here. So my last point is, how can we integrate now into precision medicine? So in precision medicine, you can look at the genome, you can see what the mutation patterns are and make some recommendations. Well, I would argue to you that we are probably getting close to doing the same thing in immunology. And in fact, already we can begin to differentiate what tumors have T cells. If they're T cell inflamed, they're very likely to respond to some of these immunotherapy agents. If they don't have T cells to begin with, something fairly simple to get from our pathology colleagues, we might want to give them something like an oncolytic virus or a BRAF inhibitor that will allow the T cells to come in. We may want to look at PD-L1 expression. I think we have a little bit of work to do around the assays there. But we will be able to understand what is suppressing an individual patient's tumor and then probably go to the best possible immunotherapy agent or combination with targeted therapies. And the whole concept of immunogenomics and what may be going on in the mutation level that might be influencing the immune response is really in its infancy, but there is some interesting work going out there. So these are just some of the people I get to work with, and I will stop there. Thank you.